Do you mind just
Good morning, everyone. So this is the joint meeting of the Consumer Healthcare Investment Institute and Consumer Involvement, Community Healthcare Investment, Consumer Involvement Committee, and the Cost Trend Market Performance Committee. So it's a pleasure to see everyone. The first item that we have on the agenda is we have the minutes from our joint meeting on July 5th, which was a couple of months ago at this point. And so we need to approve the minutes. So, yes, is there a motion to approve the minutes? I'll move. Any second? Okay, all those in favor of approval? Aye. Anyone in opposition or abstention? Okay, so the minutes have been approved. We want to start off today with in the first part of the meeting. We're going to talk about some care delivery investments and chart phase 2 investment program. And then we're going to start to move into the appropriate care and post-transaction impacts of discharges. But where we want to start off is with care delivery investments. And do I turn over to you, Katie, to lead us through this? Thank you so much.
Thank you. So I am joined by Mark Denise, our Deputy Director of Strategic Investment. Kathleen Conley, our Director, unfortunately, has a sick kid today. So Mark is going to be an excellent pinch hitter. So we'll tag team this presentation. You know, the premise here is we have been thinking about what our next round of investments is going to be. And we're putting forth a proposal today for how we could potentially design a program around $10 million that we have left in our customers. So that's the goal of the presentation today. And this reflects some pretty preliminary thinking, some preliminary conversations with stakeholders for the committee's reaction. So we'll start with the goals and principles of our care transformation work. And please, interrupt me and correct me if I say anything wrong. But as we think about the goals of these investments, it's pretty broadly consistent with our other goals of our care delivery work: transform care for people's families and communities, meet target aims, including those of readmissions and EDUs, and promote other state policy priorities such as the opioid epidemic and integrating behavioral health. Principle of investments, this is a slight reframing of work that you've seen before. The one important one I'll point you to is meeting providers where they are. I think it's really important to us to think about providers in Massachusetts on this continuum of integration and continuum of accountable care, and being able to move them along incrementally and not expect everybody to get to a certain point. And so using investments to promote that. And obviously, given everything else going on that we've talked about in this morning's committee, being in close alignment with the Mass Health Care Delivery Transformation. Any questions on that? So, as I said at the outset, this is a proposal to allocate around $10 million from our trust fund, both the Distressed Hospital Trust Fund, which, as you know, statutorily has to go to those chart-eligible facilities, and then the Payment Reform Trust Fund, which has a broader group of potential awardees, both intended to be grant-focused programs. And so that's what we'll talk about today.
Okay, so 10 million and both of them combined.
Correct.
Okay.
Yep, and so we'll have to, as part of this, you'll see about who we think of as eligible entities for these awards. There'll just have to be some math. Obviously, some of it will have to go to those chart-eligible hospitals, and then some of it can go to other types of systems. So, we've learned a lot through our couple years of experience in both through CHART and the Innovation Investment Awards that are getting started now. It's been $80 million worth of awards and working over the course of 75 different grants. And so I won't go through all of this, but I'll point you to 3 of them that we think are really important to consider when designing this next round of investments. One is focusing on a parsimonious set of measures. I think we've kind of gone back and forth historically with how much reporting we require of awardees, and trying to really hone in on a core set of measures that we require reporting on, and we'll talk about that a little bit later. Also requiring in-kind contributions. This is the remaining bulk of the trust fund money, and so really imperative to us about, that the work can continue after this grant funding ends. And so requiring in-kind contributions and really strong sustainability plans as part of this investment program will be critical. And then finally, building the evidence base is also something that we've talked about. The evidence base around care delivery models and how they can contribute to health outcomes and importantly, efficiency and reduction in costs. And so there's a lot of care models out there in the behavioral health integration space and in the social determinant space, as we talked about in the hearings, that don't necessarily meet the sort of what I call the CFO tests. Like, would a CFO of an ACO continue to fund this program or any healthcare system, and why? So using this program to be able to contribute to that evidence base is really important.
Is in-kind contributions strictly human resource costs or other costs?
Could be, we're leaving it pretty broad, and so it could be, Margaret will go through a slide where exactly that distribution that we're thinking of for reaction from the committee. So it could be in-kind resources adding up to about 25% of the grant or actual monies. Okay. So here's the big proposal. No surprise to anyone, the next round of funding should focus on reducing avoidable acute care utilization. This was a major theme of the cost trends hearing, and it is a major theme of our work here at the Policy Commission. And so these statistics are not new to you, but the important, continuing the important work of CHART and highlighting where care delivery innovations can promote reductions in acute care utilizations, both in the ED setting and in the inpatient setting. So since we're coming right out of the cost trends hearings, we thought it would be interesting to think about, how the themes that we heard from those 2 days could help the design for this investment pool. So we heard a wonderful presentation from Dr. Maddox about, how the readmissions measurement is challenging for safety net institutions and about the vulnerable populations and how we can target resources to help them reduce acute care utilizations as being sort of the biggest bang for our buck. Through pre-filed testimony, we heard from a majority of providers and payers that reducing unnecessary acute care utilization was a priority for them, a top priority for them. We also heard about community appropriate care and how we at the Health Policy Commission should use our policy agenda to help drive care to community-based settings where clinically appropriate. And then finally, from Ray's presentation and David Auerbach's presentation, how behavioral health diagnoses relate to an increased readmissions rate, and being able to focus on that population as a critical way to reduce overall acute care use. So related, through the work of the community hospital study and our investment programs historically, we want to continue to promote community-based healthcare systems. One way to continue to bring care to the community is to be able to make sure that those community-based health systems are sustainable and have the resources they need to transform. And so this is a quote that from the community hospital study that we really love, but importantly showing all the different types of partners, and I say community partners, not necessarily in the mass health definition, which everybody takes it as when I say it these days, but very, very broadly, all the kinds of social service organizations, specialists, hospitals, primary care, schools, any kind of community-based organization, local departments of public health, that should be working together to tackle the issue of acute care use and promoting and strengthening community-based healthcare systems. So I'll go pretty quickly through the evidence. None of this is new to any of you, but in thinking about how we would frame a program around reducing avoidable acute care use, clearly social determinants of health drive acute care use. And this slide presents some data about the role of homelessness and the role of some mental health diagnoses in driving acute care utilization. This is a slide that Ray presented at the cost trends hearings. Behavioral health comorbidities and diagnoses themselves certainly drive readmissions rate, and that's a really important thing for us to think about. So with that evidence and that framing, I will turn it over to Margaret to take us through the design proposal today, but I'll pause to see if you all have any questions.
Okay, thank you, Katie. Hearing no questions, I'd like to present the details of the proposed funding program design for your reaction. As Katie alluded to, the design is informed by feedback from community hospital stakeholders, ACO stakeholders, advocacy stakeholders, as well as expert consultants, and of course the HBC's 4 years of experience administering $80 million in awards. So we propose 2 funding tracks, again aiming to reduce avoidable acute care utilization. For the first track, we seek bids for programs addressing social determinants of health after an acute care visit or emergency department stay in order to prevent future acute utilization. And here, partnership with social service providers and community-based organizations is required, and we absolutely want to see dollars pass through these organizations in this type of partnership. For the second track, we seek bids for models that increase access to behavioral health services at the point that patients need them. So think open access, think real time, and we're serious about integration. And so for medical care providers that are the bidder on the award, partnership with an outpatient behavioral health provider will be required, as well as the reverse for BH bidders. We're looking to see medical provider on the bid as a partner. We do call out a specific focus on opioid use disorder treatment, seeking bids from hospitals to further test ED-initiated pharmacologic treatment for substance use disorder, aiming to increase rates of engagement and retention in treatment. And the 2016 legislation does direct HBC to direct $3 million toward these types of programs. For all of these, our hope is to provide examples to the market, giving descriptions of the types of programs we will be interested in funding, while not limiting allowable bids to these types of examples. We really do want to see the best ideas that the market can put forward, bolstered by an evidence base. And I'll note further, as the slide indicates, eligible entities include HBC certified ACOs, including those provisionally certified, as well as their participants, and as well as chart hospitals. Please.
On funding track 1, is there any thought to doing supporting something that's a little further upstream? Because we've already said social determinants are a major factor, but if you already had the acute visit, you're already behind the 8 ball. So if there's a way to anticipate or find that person who has housing instability before they ever enter the hospital, or some other way to figure out how to fund more upstream services. Is there any thought about that?
I think that's an important question and something that we have discussed at length. How much do we want these to be more public health oriented types of interventions versus with only 10 million, how much do we really need to focus this in some way, focus permits, an ability to evaluate, to improve that evidence base, as Katie alluded to, ahead of time. And so that's the recommendation we landed on.
Yeah, I think it's a great point of discussion, and we actually just internally discussed this yesterday, as to whether anchoring it in this way makes sense. My perspective on it is that this is not a huge amount of money to tackle social determinants like housing, for example, and so being able to focus the target population, so exactly as Margaret said, so that we can contribute to that utilization correlation.
Right. Maybe I'm asking, can you target that population before they have?
Absolutely. So I think that it's a good point for us to discuss whether we want to make it broader. I will also say that we've heard from stakeholders that this one seems a little bit broad, and it is intentionally so. As Margaret said, we want to get the best ideas that the market has and be able to support those. ideas where there is an evidence base and there is a sustainability plan and there's a commitment from the organization. And so, should we just focus on housing, or should we just focus on, any one particular or a couple particular social determinants? We internally have landed on this language, which keeps it appropriately broad, so that we don't limit innovation. But thinking about, because of the money and making that direct relationship to a reduction in readmissions as our sort of guiding star here, having it be post an acute care visit makes sense, but would love feedback on that.
All right, other questions about the two tracks? Thank you. As Katie said, utilizing funds from both the Payment Informed Trust Fund and the Distressed Hospital Trust Fund, we propose a $10 million opportunity in total, capping awards at $750,000 for a program duration of 18 to 24 months. And now, please.
One of the concerns I have is limiting the grant to $750,000, and when you look at the in-kind contribution of 25%, you're still looking at over $1 million. Have you looked at potentially increasing the grant size, limiting the number of institutions involved, potentially getting more measurable results? Because $1 million is not a lot for a program like this.
That's a great question, and something we'd love input from the committee on. Our thinking is we wanted to fund a number of awards and not keep it too narrow. We have done some modeling on some of the types of programs we'd be interested in funding, and absolutely, there's an upfront investment. But for that, the subtract focus on opioid use disorder treatment, we think this is a reasonable funding cap size, limiting it to 1.5 to 2 years. And so very open to that type of discussion.
It's also consistent with our HCII cap that we use for the HCII awards. And importantly, we found that our money, in a couple instances, actually led to like a lot more in-kind money. Just like you can see in your live presentation, I don't know who was there for Blue's presentation, but because they received our $750,000 grant, they were able to receive a lot more. And that's a housing project, right? So there's some that are going to be much more expensive than others. We've heard feedback across the board. Marty Cohen, for example, said, "Whoa, $750 seems like a lot. You could potentially get people started with less," and other folks said, exactly as you're saying, it's on them. So
I think, Commissioner, to your point, reasonable people can come up with a different number here, and I think we really are truly kind of looking for some guidance and feedback from the board here. And I should note, all of part of our next steps here is to bring this to the board for discussion, even prior to asking for it approval from the board. We want to be able to have that full board discussion. So this is a key decision point. How much? How many awards? I'm open. I think we're all open to further thoughts on it from other commissioners as well.
I wonder whether it would make sense to come back to this after we do the next couple of items, because I'm curious about what we learned from charter phase 2 and other awards that feeds into this. Like what things have we found have the biggest impact in terms of the results that we observe at the end of the day, or processes that look like they're being changed, whether we observe the outcomes or not at this point. But I sort of feel like I'm a little bit in left field in terms of what to recommend.
I think that's a great point, and we'll talk a little bit more about CHART, but just as a reminder, CHART had awards that were as small as $1.3 million
Yeah, and smaller in some
over
cases.
24-month period, and some that were close
But
to
even the
4.
scale of what we want to do.
Right.
If we say, like, for example, one thing that might have come out of the chart, I'm not saying this is, because I don't know it is, the only projects that seem to have the biggest impact are the biggest projects.
and I don't think that's
Either go big or go home.
Yeah.
It could have been a conclusion. And if that's so, then that says, okay, look, you really need to go there. Or if it was, no, actually, the bigger projects just kind of stepped on themselves a bunch and really a little bit of seed money every now and then was right. Or, what we learned is that if they've done a bunch of pre-work with the community, that was helpful. If they hadn't done anything much, it was just too hard to get up to speed. So there are a bunch of lessons we could have learned that would then influence how we want to go here.
Well, I think it's maybe worth just pausing on this point for a minute because we have Margaret here. I mean, what are
Yeah,
your
let's
perspectives on
talk
this?
about it. I mean, we've found that it's not necessarily the larger awards that are having the blockbuster results. In a lot of cases, a smaller, nimble team can really drive to some good outcomes. And I'll steal some thunder from Lauren Melby, our manager for learning and dissemination, to say that we're finding that the chart phase 2 funded a lot of lower cost types of staff. We're not paying for physician salary on physician salary. That's not what this is about. And so the dollar can stretch a bit. And to you made a great observation about preparation, and that's something that we learned in chart phase 2. We did spend a lot of time in planning, but moved from sort of further upstream planning to implementation perhaps a little quickly. And what we did instead in HCII is earmark a period of 3 to 6 months for really not planning, but operational planning. And so hire the people and deploy the technology and begin laying on the ground work for the initiative. And so contemplating having a similar type of preparation period here. So low spending rate typically during that period, but it sets the teams up for a lot of success.
And I would also, I think another piece of the decision-making process here is the sustainability piece. Commissioner, you have challenged us many times to think about what is the return on investment. If you know, and Katie said at the CFO test, if there's not a business case that the institutions have to continue this work, then that's going to be a real problem for us to be able to say we're credibly moving this forward, and that these aren't going to be short delineated programs. I think some of our experience in chart phase 2 is that the smaller awards have been, you know, the hospital willing to kind of step in and fill that gap afterwards and be able to dedicate that funds to continue the program, because they can say, okay, well, this is a manageable amount of money, I'm getting a lot of return in terms of the quality of patient care. And if it was, you know, for example, a $5 million award that we're paying a lot for, that's a big gap that institution now would have to step in and continue to fund on their own. So the sustainability question, I think, feeds into this as well. I think in some of our bigger chart awards where it's more money, we've seen that the hospitals want to continue the program, but they're going to have to do it scaled down. And so another reflection, Mark, I don't know if you want to add to that.
I think that's right. And the chart hospitals are all either recently concluded a planning process for the future of their chart programs, or they're engaged in that work right now. And what we're seeing at a number of the campuses is this sort of strategic planning sustainability work has elevated a conversation internally about the chart model from, you know, this great program that's happening in the ED or it's happening in the community to really to the CFO test and to front and center in front of hospital leadership and in many cases in front of ACO leadership. So we need a population health strategy, and we've got this chart model, and what components do we want to bring on forward into the future?
Can I ask a question? You brought up a very interesting point. Let's say, for example, someone had a $5 million and there was a positive ROI at the end of the period. Now they need to make a decision. They can scale it down. They can fund the whole thing. Are they looking at a break even over a period of time? Are they looking at where we're going to get the funding to kick it off and what's available? How are they? Have we looked at how they're making that decision in terms of whether to scale down, or if the ROI has to hit a certain point where these guys are saying, man, it is definitely worth the investment. Have you looked at how they've made those decisions? Because that would be very helpful for us as well.
Absolutely, it would, and we have some amount of visibility into that through this strategic planning process, and we hope to be able to bring some aggregated insights in front of you. It would be premature to comment on that now as we're sort of engaged in that work today, but we're seeing, I'd say, some variation in detail into sort of showing their work. What does it take to break even? Because we fund some fixed costs in chart, and we fund some staff time and variable costs as well. So
I would say it's a great point, Commissioner, and one that I think we can mine some information to help inform us here. I think anecdotally, there's some variability. I think, you know, in some cases, you know, even in some organizations, we had a chart meeting earlier this week with all of the chart hospitals. We got to hear a little bit about what they're thinking for the future. in some cases where it was a big award, they're talking about scaling down, but still thinking that they're going to be able to have the same amount of impact. That they, over the course of the 2 years with Chart, they figured out what the best model is. And it took some time. There was a lot of upfront investment, but now they say, okay, our run rate can be something smaller than that on a go-forward basis. And we can still think that we're going to have all the same positive impacts, which I think we would say that's great. And in other cases, it's really a decision of the leadership of the organizations to say, we think this is good for our community, even if maybe it's still an investment of our financial resources, that we're seeing really good patient quality outcomes out of this, and willing to make an investment in that. And so, needless to say, I think there are a lot of different decisions that people are making here. I think, again, when we're thinking about a next round of grants, one of the most competitive factors is going to be, what is your plan for sustaining this? And how are you going to be able to do that? Because we don't want to be funding grants, especially with the last dollars we have in this trust fund, for programs that are going to go away as soon as the grants.
The goal here, and everybody we've talked to, these are critical goals for institutions. So the decision comes down to, they have a list that they can invest in. Benefit the community, benefit the patient, benefit the organization. They weight the variables. And they only have so much money they can spend, right? And the question becomes, it doesn't matter what business you're in, and the question becomes, given what we have, and when we weight this, here's what falls into getting funded, here's what doesn't. Even if it succeeded, they may find they get more bang out of their buck with another program, right? So do we look at that in terms of, if this is as critical an issue in the business, this should be up there. And the question becomes, if it is successful, how long of a break even are these guys willing to eat in terms of adopting the program? Accepting the grant is one thing. When it's on their nickel, how long are they willing to eat losses to break even? And I think that's something we need to know up front. Again, whether it's a small grant or a large grant. I think those are, I don't know, you guys may always be doing this.
This is absolutely what we're spending our time thinking about. I think, one reflection is the areas that we're focusing on: behavioral health, social determinants of health, to reduce acute care utilization. We heard these are the top priorities. Like, we asked the providers, and they said these are the things that we want to work on. And so I do think that they're top priorities, and would we have sustainability just from that. I think the other big important contextual piece here is the Mass Health payment reforms, and to the extent that those will create more of a financial reward and incentive for organizations that are being successful here, will be a different context for the providers as part of this proposal than even some of the Chart hospitals, which those programs are ending right now. We heard from the Chart hospitals, the ones that, many of them are continuing their programs, and they're continuing their programs with an idea that they're going to be financially rewarded under the new Mass Health payment rules. And what that runway looks like and how long it takes, I think, is a really tricky question, but I think one that we need to reflect on when we think about how long do we want to do this, and how much money and the design of this program. It's a really good question.
We have heard from the Mass Health team, all systems have had to put in their applications for the district funding, and they've gotten a lot of proposals to continue the Chart program. Importantly, the district money goes to the ACO and not to the hospital, and so in a lot of cases, they're kind of amending their program to not sit within the hospital, but sit within the population health management strategy of the ACO. That's exactly what we want to see. And so we'll be able to, that being said, not all Chart Phase 2 hospitals are in a Mass Health ACO, and so I think we'll just have to be, critical of proposals to make sure that they are in these risk models such that the work can potentially continue.
One additional point, just in terms of a factor to consider in terms of award size. I think we have always thought that this isn't necessarily just about the improvement in a select number of organizations that we're grant funding, but to be able to use these as incubators and test sites to then be able to say, this model works, and now we're going to spread that more widely. And I guess I would worry a little bit that if we just said, all right, we're going to fund 2 ideas at $5 million a piece, that will have a dramatic change in those organizations, but we may not be able to have kind of a variety of different ideas that are being put out that we could then learn from and be able to spread to a bunch of different types of organizations doing a bunch of different things. And so weighing kind of the ability to have some variety in the innovations that we're supporting versus having kind of deep impact, I think, is another factor in terms of how many awards do you want to do. Deep impact for that organization, but maybe we're losing a little bit of the ability to let a bunch of new ideas come forward.
You know what's interesting? If a program's successful, whether it's a large grant or a small grant, and the organization makes the decision not to continue with the program, if it meets ROI and they decided not to continue with the program, that's an interesting issue because how many other organizations, like you said, are going to adopt something that the organization that received the grant decided not to go forward with? So I think it's critical to understand how they're going to make those decisions going forward at the end of the program. I think we need to know that up front. I think that benefits everyone.
Yeah.
Can I just come back to an issue that David Sumsey raised a minute ago? And that's what, if anything, we've learned about the ability to take programs from one organization to another. And whether each program is sort of a unicorn, that is, each one is individual and you just can't pick it up and transfer it, or whether what we've learned is no, actually you can transfer it. That maybe not you don't do it exactly the same way, but they simply sort of have the same kind of structure, and then you can reasonably expect the same sorts of outcomes.
I'd say what we're seeing, we have the best insight into that in HCII, in the Healthcare Innovation Investment Programs, because these are intended to pick up a model from somewhere else and adapt it to the awardees of the environment. And I'd say that they're not turnkey solutions. You don't pick up the model, throw it in, and all of a sudden you've got these results. There's culture change that's needed, there's adaptations to the community, to the set of stakeholders at the table for that particular environment. And that's what we're sort of observing right now in HCII. I think that the challenges related to hiring and training, challenges related to information systems and technology, and then challenges exactly to that point related to implementing a new model in one's own environment. I think we should expect these challenges, and I think we're going to see them at least to some extent in any work that we fund at this stage. But what we'd like to be doing as we're learning is find opportunities to make that learning and that adaptation happen more quickly. That's something that we're thinking a lot about in conjunction with our learning and dissemination strategy.
I would add just a few thoughts on this particular point. I mean, I think one of the things that we're thinking about in terms of a kind of a competitive factor for our evaluation is that to the extent that this is, let's say, a hospital that's applying for an award and they're part of an ACO, we want to hear as part of their application, how are they communicating and working with the ACO such that if the program works, that ACO is then translating that program to all of the other component hospitals in that ACO. And I think the ACO becomes a place where we can say, show us your plan, show us exactly how you're going to do that. That's kind of on the move forward basis. On a more kind of retrospective basis, Professor Cutler, we just had this chart convening, and I think it was really instructive. There absolutely were things that hospitals were doing that they learned from other hospitals and picked up and adopted and said, that works over there. You've said that works. I'm excited about that. I'm going to take that over here. And an example of that is, there was incorporating, just a real practical example, incorporating into the emergency department basically information that when a patient shows up in the emergency department, that the attending physician, the ED physician, can have a care plan in place for this patient. We know who this patient is, we know what their needs are. They come in with high anxiety on a regular basis. Here's the treatment protocol, here's their PCP, here's their social worker. Call this and get that information directly in front of the eyes of the emergency physician. And that's kind of an alert, that's a care plan that we are identifying for a high need complex patient. multiple hospitals picked up this idea from each other and said, we're going to incorporate that into our model too. Now, the intervention might be different in certain circumstances. In some cases, they may say, all right, we're going to send a social worker to that person's home, or in other cases, we're going to call them, or it may change depending on what the intervention was, but identifying these high-need patients, being able to put information on some of the nuts and bolts of how you address complex patients, absolutely we can spread. And I think the really exciting thing coming out of CHART is that we can create these blueprints and basically hand them out to hospitals and say, here's what worked in CHART, here's how to do it, here are the component pieces. You may have to adapt this for your own hospital and for your own staffing and for some of your own patient populations, but here are some very practical, tactical things that hospitals can do and care teams can do in order to address this. And so, you know, it might not be the exact same care team or the exact same model, but it can, those component pieces can translate.
Just to follow this up and then we'll turn it over to Carol, that suggests that in this particular award, maybe we should say, look, before making the awards, we'll try and do some synopsis of who's done things that are similar and what we've learned from them. And then as part of that, we want you to start off during the planning phase maybe and go talk to the other institutions that have done programs like what you're proposing to do, so that you have that guidance right off the bat, so you don't have to rediscover what four of the previous CHART hospitals discovered when they tried to do
I think that's a great idea, and I think absolutely in line with really how we're thinking about the CHART hospitals and that cohort moving forward, is using them as ambassadors in many cases to, you know, help the next round, help that next innovation, be able to translate. We did this, you know, hospitals have been working on this really hard for 2 years, and in some cases it took them, you know, 1 year, 11 months to, you know, get it completely right and super successful. But now they have that, they're going to continue that. We should not be asking other hospitals or care teams to spend an hour, you know, a year and 11 months getting to that same place. We should get them going right at that most critical phase. And I think that deploying the learnings from the CHART phase 2, I think is absolutely critical to our work going forward, not just in this investment program, but I think writ large, where many of them are going to be at financial risk through the Mass Health contract to do these types of activities.
So I guess I'm the provider in the room, so just from my own personal experience, first of all, you mentioned culture change. Culture definitely is strategy for lunch, so you know, every different system, every even unit is going to have a different culture, and how things play out is going to differ, so that's a big challenge in terms of change. Even within large systems, where when I worked in the system, we had many different practices within the system. Every practice, even giving them the same, you know, the same set of needs, the same types of patients, they all had different ways of wanting to do things. So it was very hard to get standard care, which I think that, but I do think that a lot of medical systems now are looking at ways to standardize some kinds of care, just because they need to, partly, and because they understand that it's a way to get better quality, and that actually having a standardized way of care gives you the flexibility to deal with the outliers. That you don't have that if everybody's doing 10 different things. So I think the ambassador idea is really great, and I was wondering about actually doing grand rounds in different hospitals. That one way to promote to spread is to have people who've done it be invited to speak at somebody else's grand rounds, because I think that gets at the culture issue. Physicians listen to physicians and are very curious and interested in what has worked. So something you might think about in terms of spread.
One, just to jump ahead for a second to answer your question about culture, one thing that we've been thinking of will be critical to assess in the competitive factors is alignment with organizational strategy and leadership, and it's really hard to tell in a proposal whether the leadership is committed to this kind of project. I mean, you can get somebody's resume and you're like, that person has 9 Ivy League degrees, it sounds like a good plan. But that is not at all what means that the program or the project is going to work with the cultural and the strategic vision of that organization. And so I think we've been thinking about more the role of interviews and sort of bringing people in person to sort of get a better feel. Us as a group of non-clinicians are not necessarily going to be able to assess the culture of an organization, but we can do our best to try to develop a robust process so that we can ensure that we get over that hurdle. And we've seen that through the investment programs, that where it is not aligned with the strategic vision of the organization and there is not that leadership buy-in, it is not sustainable.
My guess is we need to keep moving.
Yes.
Have we given them that guidance? Or
There's one part I want to just quickly underscore on this slide. We've made mention of this in the discussion, but it would be new for the HBC's investment programs to have this kind of matching model where the awardee incurs an eligible expense and then the HBC reimburses or recommends 75% of that cost. And it's a way to ensure that there is some kind of skin in the game for all of the organizations, and it helps smooth the path a little bit, we hope, to sustainability. So if there's questions about that, happy to discuss otherwise. So we've gone through each of the elements on this slide, some of the proposed goals, funding factors, and connection with HPC, key objectives overall, where we are in timeframe, getting the feedback from the committee, looking forward to feedback from the full board, and targeting an RFP vote in the December timeframe with releasing soon thereafter.
I will say, if anybody has any other feedback or anybody in the audience wants to talk to us about it, we are more than open to design feedback at this point when we're in the development process. So please, contact us.
So moving forward to chart phase 2, as David mentioned, we had a wonderful statewide meeting on Monday. I'm still recovering from that, and inviting Laura Melby up here, manager of learning dissemination, to talk about that.
Good morning. As was mentioned throughout this meeting on Monday, we held our second Chart Phase 2 statewide meeting in Foxborough. As many of you know, the strategic investment team has held meetings for the Chart Phase 2 cohort throughout the planning and implementation stages of the program, with the goal of engaging in shared learning. Monday's convening was different from others in that not only did we invite Chart Phase 2 hospitals and their partners, but we also opened up the invitation to a broader group of stakeholders across Massachusetts, and I think we even had some representation from other New England states, so that was exciting. And so we framed the meeting as more of a learning and dissemination event to spread lessons learned from Chart Phase 2 to a larger audience. All told, we had approximately 250 attendees, half of whom were external to Chart. These included providers and provider organizations, state government, payers, and others in the industry. The room was packed and the energy was high. The day was structured in 2 parts. In the morning, we had 4 rapid fire panels with a total of 21 panelists representing Chart Phase 2 teams. The first 3 panels focused on the various types of programs that we have in Chart Phase 2, so reducing readmissions, reducing utilization for patients with high utilization of acute care services, and including care for behavioral health patients in the emergency department. Panelists for the first 3 panels were frontline, clinical, and program managers. The 4th panel was a little bit different in that it was composed of Chart Hospital C-suite and executive leadership. And the goal here was to speak to their point of view on Chart Phase 2 with a forward-looking eye to the future. Many of them are laying the groundwork or already have laid the groundwork to sustain parts or all of their Phase 2 programs. And one noted loud and clear that Chart was indispensable in preparing for the Mass Health ACO. In the afternoon, we had 2 sets of 4 breakout sessions. This allowed Chart teams and audience members to take a deeper dive into program components. The sessions were highly interactive. There were a lot of great questions from both Chart and non-Chart audiences. And I actually just learned this morning that a payer that was present asked a specific question about the resources required to sustain these programs beyond the grant period. And another audience member, who I think was in healthcare technology, asked how chart teams are convincing their leadership to hardwire their programs and to integrate them throughout the hospital. And one team answered, anecdotally of course, that concrete, measurable outcomes for high-risk, vulnerable patients, and the recognition that these outcomes could directly reduce readmission penalties in addition to any reduced TME. So a theme throughout the day, and frankly throughout all of Chart Phase 2, is the unique makeup of Chart Phase 2 teams. This was evident in discussions throughout the day and also just looking around the room. These are the people doing this work. Of the over 250 FTEs that Chart has funded in Phase 2, a huge proportion of these, as you can see on the screen, are social workers, community health workers, navigators, peers, case managers. And as you know from the beginning, we did not endeavor to create a physician-heavy model that relied on traditional medical models. We did endeavor to encourage our hospitals to build teams that reflect their community and the needs of their community. And this is exactly what you did, and this is what you can see on this slide. Furthermore, they went beyond hiring the right role, but they also hired the right fit for the role. In a lot of these cases, we're asking team members to go outside of the norm of the day-to-day in the hospital and actually asking them to step outside of the hospital and engage patients in the community, under bridges, in coffee shops, in the home setting. And so what you see is that in Chart Phase 2, we did just that. These folks are paying attention, they're listening, they're meeting patients where they are, and they're improving care for the Commonwealth's most vulnerable populations. Any questions?
Well, I have a question. Did you hear anything from the participants, the hospitals, about difficulty filling these roles? You know, are there people out there, for example, not community health workers, or is that a challenge as well?
Answer, and you can step in. I think in some cases there was a challenge, of course, hiring up these teams, and I think another lesson learned is that some teams started their programs thinking they needed X, Y, and Z team members, and learned as they engaged in the program that actually what they needed was a community health worker instead of an RN or an NP. Some teams did take a long time to staff up.
Do we have, I don't know what degree you need to be a community health worker, but do we have programs that are training these people? It sounds like that's more of a role going forward that we're going to need more about if we're going to address social determinants.
Go ahead.
There are training programs out there, and we have had, we've funded some of the up-and-coming CHWs attending some of these, and I don't have a sense about whether there's enough training capacity for what maybe we do in the future, but certainly partnership opportunities for us to explore further.
Thanks.
So the next two slides are examples of what panelists in the first three panels presented to the audience. These were rapid fire, intended to share what makes a chart team, how many patients can they serve, what are their results, and what did they see as their success factors. In many cases, as you've heard over the last few years, these care teams are small, and what they're able to do is pretty phenomenal, and so that was evident throughout the day. So teams shared their point of view on how they got these results. And across the cohort, there is variation in success factors that were discussed, but there are a few that kind of flow throughout the cohort, and those include team makeup and who does what and when, how you do your case finding, how you engage patients and when, how you use your data to drive rapid cycle improvement and adaptation, and regular team huddles and open communication. So this is PIG Plymouth, and the next example is one from Harrington. So a little bit different team makeup, slightly higher volume, different program.
These above average successful, or these are just places that are far enough along?
I would say this is fairly average.
We have seen results like these, and the run charts that you see here, they're for the target population. It's not hospital-wide, certainly, and we also certainly focus and featured the more successful programs like the learning section. And so there were teams that did not have tremendous success, at least on their measurable aim, or their successes in their patients. Yes, successes in learning and organization and helping the workforce. Yes, but these are representative.
Is it possible as someone when we do the evaluation, is there going to be an estimate of did we save more money than the money put in?
As part of the BU evaluation, there is an ROI calculation associated with that. And I would just say, these are representative of the entire sample. All this data goes through July, so this is not through the end of their programs. These are phenomenal results. I mean, in many cases, the primary aim, the stretch aim that these hospitals had was a 20% reduction for some of these measures. And many of them thought at the beginning, we're not going to make that. And what we've seen is a lot of hospitals not only are trending that they're going to make it, but far exceed that. So I don't want to diminish what we're seeing in terms of some of the results here. And in some cases, some of the hospitals, again, the programs are focused on specific, very complex patients that are extremely high need. And the fact that we're able to, bend a trend for the hardest patients is really, truly phenomenal. And there were some hospitals who did see, anecdotally at this point, and we want to confirm all of this, but that it was having impacts across their entire patient population. So the success that they were having with the target population was actually reducing their overall readmissions rates. And that's, we're not going to see that in every hospital, obviously, given the patient volume, but, I think we should be excited. We were very excited, and I think that, the convening, everyone was very excited about what these numbers indicate.
Does it actually reduce costs?
Well, so in many, we had a good conversation about this in terms of there was one institution that actually did, kind of a back of the envelope ROI calculation and said, we think that we've avoided X amount of readmissions. We think a readmission, costs the system about $11,000. Run that out over a year. That's $1 million saved. And I think the program was probably around $1 million investment over an annual basis. To whom do those savings accrue is a more difficult question. Do they accrue to the health plans? Do they accrue to the hospital or the institution, to patients? Untangling that is going to be a challenge that we're going to be wrestling with in our evaluation. But they are savings to the system, and if we think about what are we as an HPC trying to accomplish, these are savings in terms of total healthcare spending. The question you're asking is more around how does the hospital make that financial commitment moving forward, and what is the ROI within the hospital, and that's the $1 million question, I guess. Anything to add on that, Margaret?
That's right.
Great. So I'll close here with a few quotes from the day, and there's a lot more if you follow us on Twitter. But upon reflecting on the convening over the last day, what we as a team collectively heard from the audience is that chart focused on strategy, execution, and now sustainability of population health management programs. And the audience said, the importance of sharing what we learned across that continuum of activities. And so there is an appetite for learning more from the HBC's investments among stakeholders and market participants. And in the days and weeks and months to come, our team is going to put a lot of thought into the design of what learning materials or other events we will create and share from this event and from Chart Phase 2 as a whole.
Can I just interrupt you on that? We spoke about this at the board meeting. Even without a lot of money, we can continue some of the learning efforts that we've undertaken, even if we don't perform it. And given how important these goals are to the Commonwealth as a whole, it makes a lot of sense to figure out how we should go forward, even independent of the $10 million in the funding opportunity or whatever else.
100% agree, and we've been, and Lauren has been working on what is our strategy in terms of the types of different activities. And Dr. Allen, you mentioned another idea there that I think really, as we think about Chart Phase 2 ending, yes, we're going to continue to have the innovation grant program, we'll have another round of grants, but this is a big part of this work too, is taking and being able to spread these learnings, and that's, I think, something that I think we should devote resources to. And as you said, not a lot of money.
I think we should take this up at one of our board meetings in terms of, given how we're trying to focus ourselves on some of these particular goals, how can we do it even without the chart premature?
Great.
All right. Any other questions?
So how are we doing on
I think maybe just breeze through the operation.
all right, let's breeze through the operations update. Chart Phase 2 is concluding. It's gone very, very quickly. You know that programs have a standard 24-month measurement period. We are providing the opportunity for up to 6 months, a no-cost extension for teams with available funds, and some teams are continuing the operational model, or in some cases a subset of services within the model. Some are providing transitional services to move patients to other caregivers as the model sunsets, and others are using modest amounts of remaining funds to finalize reporting requirements to the HPC, a little bit of data analyst time, a little bit of project manager time. And so as you see, about 18 teams are intended to pursue a no-cost extension of some length. So we continue to be hard at work managing the programming relationships, managing contracts, data and reporting evaluation, learning and dissemination. And to date, we've dispersed about $40 million and continue to keep you apprised of our spending. Moving on to healthcare innovation and investments, same efforts in the same areas of focus. All 20 programs are live and serving patients. Right now, our team is working with awardees on their own self-assessment plans, and we're just starting to receive reporting of key performance indicators, describing impact as well as some process measures as well. And so we're getting some increased insight into how these programs are beginning to perform, though they are early in many cases in their implementation. And so still more to go in implementation for HCII, but as we learn through these programs too, look forward to bringing that information in front of the committee. I'm happy to take questions because that was very quick.
When will we have the BU at the stage says doing the evaluation and we'll do the financial component? When will we see that?
The final report from BU, we need time to get information from CHICI. I believe we're looking at 2018 for final reporting from them, but there are interim reports that we'll be pleased to present to you over time.
On slide 34, the $40 million in estimated healthcare cost savings, can you say sort of what buckets those are in?
So these are, these typically involve a utilization of one form or another, and so as part of bids, applicants estimated if we are successful, if we meet our goal, if we implement this model, we will reduce readmissions by X, or we will reduce emergency department utilization by Y. And there's a lot that's not in there, right? There's improved access to behavioral health services among the telemedicine awards. The value to the Commonwealth is not exclusively measured in terms of to emergency department utilization, so there's a lot that's not captured there.
These are self-reported savings estimates from the applicants.
Okay, thank you.
what we wanted to do now is to have a little more discussion about the community appropriate care, community appropriate discharge issues that have come up. They came up at the cross-country hearings. And so let me turn it over.
Yes, I'll be very quick, recognizing that we're a little short on time. So we did want to build upon some of the work that we previewed at the cost trends hearing, showing how community appropriate care has changed at community hospitals and at teaching hospitals and academic medical centers before and after affiliations between community hospitals and larger systems, both contracting affiliations and acquisitions. We wanted to dive into a little more depth today on some of that work, both in terms of our methodology and findings. And before I turn it over to Amy Katzen and Rachel Salzberg, who actually led much of this work themselves, I also just want to note that this is actually part of a much larger project that our teams are engaged in, monitoring the impact of transactions after they occur. So we look forward to presenting more data as they become available on other metrics. With that, I will turn it over to Amy.
Thank you so much. So this is continuing on from what you saw at the cost trends hearing. So to examine the effects of possible acquisitions and affiliations on whether community appropriate care stayed in the community or not. We looked at a set of hospitals that were acquired between or affiliated with another provider organization between 2011 and 2015. And findings for some hospitals before, we're now adding some more information. So in all cases, these are transactions where the parties did articulate keeping care in the community as one of their primary goals. So we did that by looking at the share of community appropriate discharges in the service area of the hospital in question. And we did that because when we look at the area around the community hospital, the place where their care is coming from, we know that those are patients who in fact live within reasonable distance of a community hospital that they can go to. And when we look at share, we know that we're controlling for statewide changes or local changes in the overall number of inpatient discharges that are happening. We know that there is a general trend towards more outpatient care, so we're looking at the proportion. Even if the total number is going down, we're still looking at that share. In addition, and this will be new today, we looked at the proportion of the non-community appropriate discharges, sort of everything else, many of which are appropriate for some community hospitals, but not necessarily all community hospitals. And I do want to emphasize that for some of these transactions, not a lot of time has passed yet. So we will be continuing to monitor and see how things change over time. We know systems can change on a dime. So recognizing that in some cases not a lot of time has passed, and then also that of course these are not causal claims. We may not know why we see a trend after transaction. It may be due to factors other than the transaction. So with that, I would like to turn it over to Rachel to speak a little bit about methodology.
Thank you, Amy. Before we dive into the data, we wanted to give you a little more detail as to how we defined community appropriate discharges. It is really important to note that this methodology we did not just come up with. This is a refinement of the methodology used in the community hospital at a Crossroads study. And we worked with commissioners and we vetted the final methodology with clinicians and academic researchers.
Who did we check the researchers?
We reached out primarily on the commission, Dr. Allen and then Dr. Berwick, and in addition, folks at Ariadne looking to Megan because she led that communication. And Bruce Lynn. Yes.
And obviously this was done in consultation, close consultation with our clinical experts who are contracted through HPC, so with John Friedman and his team.
And it's important also to note that we made this methodology intentionally conservative, that there are definitely discharges that may be appropriately treated at many community hospitals, but if it was designated that these discharges could not be safely treated at almost all community hospitals in the Commonwealth, then they were excluded from our list. This slide shows the process of how we identified community appropriate discharges in a little more detail. We started with the 2015 CHICI hospital inpatient database, and we right off the bat excluded specialty hospital discharges. We also excluded categories of service that clinicians identified as requiring clinically intensive or specialized treatment, similar to this idea that we didn't want to penalize specialty hospitals or other systems if this care needed to happen at a teaching hospital or an AMC. Similarly, we excluded all DRGs with complications or comorbidities. A technical detail is that we excluded normal newborns so as not to double count the mother and the child, and this is something that we do in most analyses in the hospital inpatient database. Finally, we also made volume exclusions to ensure that community hospitals are really providing this care. So we excluded DRGs with total statewide volume below 500 discharges, as well as excluding DRGs for which community hospitals had less than 15% of statewide volume. The resulting list includes 94 DRGs classified as community appropriate, and this represents 41% of discharges in Massachusetts in 2015.
So as we shared before, as we look at the state as a whole, comparing the share of community appropriate discharges at all community hospitals to the share cared for by all teaching hospitals and AMCs, we do see that that share of community hospitals has been somewhat decreasing over time, while proportionally, of course, the share at teaching hospitals and AMCs has been going up. And I'll note that this is in spite of a lot of work that's being done and a lot of words that are being said about trying to keep care in the community. So this is, especially in the last few years, as this has been a big topic of discussion, this is nevertheless been the trend we see, and it's only very few hospitals have been able to show anything. So this is another slide from cost trend hearing, so it should look familiar to some folks. We see that Lawrence General, which affiliated as a contracting affiliate with Beth Israel Deaconess Care Organization in 2014, following that affiliation, did see a decline in its share of community appropriate discharges in its local area. So again, this is in its primary service area.
One of the things that came out at the cost trends hearing was the desire to look at, in particular, which teaching and AMCs did these patients go to. So I think there was an example at one point where Cooley Dickinson lost patients, but they weren't going to partners.
Right.
They were going to Bay State. And I think it would be important to separate those out, because what we really want in that circumstance, just to take that one example, is, for example, partners to say, look, we don't need you to send your patients down to us. The ones that are appropriate, we can keep there. If Bay State is doing something that attracts those patients for some other reason, we not really want to put that on that particular affiliation.
Absolutely. So in this particular case, we did look into it. I have some high-level notes, and then Rachel has all the data, so we can, if we want to take the time to look at the raw data, we can.
Let's go number by number.
Time will pass. So in Lawrence General's PSA, so Big Mix share is not increasing here. So we have an affiliation with the Beth Israel Deaconess Contracting Organization, and we do not see an increase in Beth Israel Deaconess Medical Center share. So that all teaching AMC is not particularly a big thing. Non-BIDCO hospitals are getting share, both teaching AMC and other community hospitals. So you look and you see that decrease on the Lawrence General share, and you see the increase in all teaching AMC, and they are not the same. This is not representing 100%, right? There's the bucket of teaching hospitals, community hospitals that are not Lawrence General, and they're not there because it was a lot of lines on graph.
But we should maybe show 4 lines on the graph. We should show, like, the equivalent of the Lawrence General, then the equivalent of the BIDCO, then other AMCs or teaching hospitals, and then other community hospitals.
But no, that Rachel's not all of And so those lines could be on
But just in
file.
terms of like what we
Yeah.
presented and stuff, I think that would be an interesting way to do
Is there anything that jumps out that you want to share at this moment?
I do want to note just for context that in the transactions that we're speaking about, there has been a goal stated to essentially capture more community appropriate care. So it's not simply a dynamic of after an affiliation, folks are getting kind of shipped downtown to the affiliated AMC, but nonetheless, we still think that some of the trends that we're seeing aren't necessarily representing kind of systems that have achieved success yet for the goals that
it.
they've
Well, because we've seen
expressed.
them all and see what's going on.
Absolutely.
I'm curious to what extent this is a moving target, because we're talking about community appropriate inpatient care, but more and more care may actually go into the home. An example this is my brother-in-law had, out in California though, had endocarditis, for which I would have assumed he'd be in the hospital forever. He was in the hospital 2 days and then sent home for IV treatment. So, so we have to have that in the background about where is the care most appropriate, not necessarily in the hospital, and how do we track that? And also the other thing is what's community appropriate, because not all community hospitals used to have capabilities to do certain things, say cardiac cath, for example, and now they almost all do, or use of certain technologies in surgery, another example. So, you kind of have to keep in mind what's the background, or what's, and look at that as well, I think, to where is care where does care belong, and where is it being delivered overall.
Those are excellent points, and actually they highlight two of the methodological decisions that we made in this analysis. So first of all, as the team highlighted, we looked at shares of discharges, recognizing that care is appropriately shifting from inpatient to outpatient settings, and I think in the future we would love to look at whether or not there is additional care that should be shifting. But here we wanted to just focus on those shares of inpatient so that we can essentially control for that. And I apologize, I forgot the second point that you just raised.
That there's some complex services that
Community
need-
hospitals.
Oh, yes, exactly. Exactly, and so that is exactly why we focused on this extremely conservative set of discharges. I believe that actually cardiac catheterizations are excluded. So we're really talking about very low acuity care that pretty much all community hospitals could provide.
But we do care about the other ones too.
Yeah, I
Actually,
would think
they're on the next slide.
Can I ask you a question? Is it fair to state that regardless of acquisitions and the industry's trying to focus on a community setting, it's not working, and people are not focused on the community setting period, and that's declining, and do you see anything that's changing that trend?
So we see different patterns for different institutions, and we'll go through them in this slide deck. It's true that it's not, the overall pattern in the Commonwealth does not suggest a huge amount of confidence. But what I like to keep in mind is, I don't know what the true counterfactual is. If everyone wasn't working so hard, what would it look like? It probably would be worse. So I don't want to suggest that all of the effort that we are told is happening is not yielding any benefits. And I think that there may be still a lot of story left to tell, particularly as we get more data as time goes on. So I would be reluctant to make too strong of a claim. But yeah, that definitely does. You want to see the next slide? So, like I said, we do care about the other local discharges. So here we're looking at Orange County's share of the discharges that we did not classify as community appropriate. Some of them may well be appropriate to Lawrence General, but we did not determine that in a particular way. So here we see that that trend line looks pretty flat after the affiliation. So what we don't see here, and what we were kind of looking to see whether we saw, was a backfilling. Like, oh, well, we're having fewer and fewer of the community appropriate, and that's because we're shifting towards higher acuity care. And that we don't see. We don't see a sort of increase that cancels out that decrease in the community appropriate space. So we also looked at, and this is new, from since Kafka. We are also looking at other hospitals that had affiliations with VIDCO. So here we have Anna Jakes, and Anna Jakes also shows a decline in its share of the community appropriate discharges from its local service area following its affiliation with VIDCO. And here you see an uptick in the share that the teaching hospitals and AMCs have in this space. And both of those trends are a good bit faster than the statewide trend. And here I'll note that BIDVIC does represent a meaningful portion of those teaching AMCs, unlike in the more general space. Looking again at sort of the inverse, so these are the discharges that were not classified as community appropriate, and again, we're not seeing an uptick that makes it look like what's happening to Anna Jakes is just shifting towards a lot more higher acuity care.
Make it look like Anna Jakes is in trouble.
Well, I'm not going to comment on that. I don't. This data doesn't. I don't know. So now here we have Cambridge Health Alliance. Of course, Cambridge Health Alliance is a teaching hospital. It is not a community hospital. It's here though in our data because just as with the affiliations with Lawrence General and Anna Jakes, here the parties did speak to keeping care at the sort of local hospital at CHA rather than a downtown AMC. So a similar goal was in place, and so we wanted to look at that data as well. And I'll note that here the teaching that had the orange line, the teaching AMC line, does not include CHA. In general, it does, but not on this slide because that wouldn't make sense. And so again, we don't see that there's an improvement in the situation for CHA after. The other thing that's distinctive about this slide is that unlike for most of them, the orange line for teaching in AMCs is above and pretty significantly. We have to cut out the middle of the graph, otherwise it didn't want to fit on the slide. And that's really about where CHA is located. Its service area is so close to the downtown AMCs, and so we think that when we look at that service area, it's not terribly surprising that a lot of the care is going to teaching hospitals other than CHA. That doesn't explain the trend, but just to note that level is probably a hard fact of geography.
Do you know if any of the CHA physicians shifted the care they were providing to the downtown? You know, in other words, if they were credentialed to two hospitals, okay, so now could they now be providing the care at the VI instead of at Cambridge for a variety of reasons? You know, if it's different providers for the same providers. I don't know. So I could have. That's
a great question.
Well, maybe it's just their new friends, but you know, they were encouraged.
It's worth running down. So again, when we look at the discharges that were not in that community appropriate bucket, we again don't see a backfilling sort of action happening. We don't see a big drop, but it's not making up for it. Now turning to
Maybe just in the interest of time, maybe let's just show one more PI on it.
yes.
And the other ones we covered in the public experience.
I can also put that there. All right, BID per minute looks different, and it's important that it looks different. So after the affiliation in 2014, we see a rebounding of their share of cats in their local service area. That is different from the statewide trend. We see a very slight increase in the share that all teaching in AMCs had, but it's slower than the statewide trend. It's a different pattern, and it looks similar when we look at the other discharges as well. That sort of rebounding.
Well, there was a dramatic decrease before the affiliation, right? There was something going on there that.
In general, thinking about the geography of that, I think that was primarily about other community hospitals more than AMC's and teaching hospitals there. So just knowing who their competition is.
If I recall, basically what we heard from hospital experiences, that area was overwhelmed. We already closed one hospital. There's still too many there. And so the BI is basically looking to patients to consolidate. I think Plymouth is now getting or something that was not getting.
For what it's worth, Milton's state is my
There
summary
was,
of
there was one thing where they said, yeah, just basically just went together. And maybe that Plymouth is one of those places that they're letting us on the verge and all this stuff.
So, Willie Dickinson, we see, because again, losing shares of CAD both to teaching AMCs primarily based in Medical Center and local community hospitals that are not Willie Dickinson as well. And the pattern does not look different, maybe really look to the other kinds of discharges.
We can just wrap up. We've already shown all of it.
Ah, yes, okay.
For overtime, but it's just some kind of.
Final word is,
Yeah, so on the slides that we skipped over, do just want to note, we do have some slides here showing kind of what happened to the all other discharges. In general, the trend was that if we saw a decreasing share of community appropriate discharges, we did not see that being made up for in the other set of discharges. So kind of overall, that's something that we see across most of the transactions that we looked at. And then as I noted up top, this is just one very small segment of the ongoing work that we're doing monitoring transactions post closure, and we look forward to speaking more about those in the future, particularly as more data becomes available. The discharge data is actually some of the most recent data that we have available to us. Some of these other metrics are more lagged.
So, David, is our goal to put this either in our annual report or to put out a special brief on it?
So I don't think that we landed on what the best way to publish or make public these results. I mean, obviously they're public now, but open to ideas and suggestions.
I think we should, I don't feel strongly because I haven't thought through it much. I think putting out a special document that says, here's what people claimed and here's what we concluded. And I think the answer is in some cases, folks have lived up to what they said. And in many cases, they haven't. And therefore, that makes us a bit skeptical about claims that we hear that say, we're going to let us consolidate and we're going to keep discharges in the community. That we should take that with 5/6 of a grain of salt.
Yeah. I think the one challenge, I agree with the sentiment. I think the one challenge here is having kind of firm conclusions one way or the other. In some cases, the trends we're seeing, it's very hard to say they're succeeding, they're failing, and so it just may have to be more of a kind of a description of what the trends are. And in places where we haven't seen that trend improve, caveating that a little bit to say yet, and recognizing that in some cases there's 2 years of data.
Don't get too wishy-washy. I mean, this is what was promised from the Commonwealth. If you can't see it yet, that's a thing to say.
It was interesting. David and I were on a panel at the Mass Association of Health Plan Conference on Friday, and this topic came up, and the question was, when these transactions come before us, should we ask the hospitals for specific metrics if they're saying that keep care in the community or increase the care that's provided in the community? Should we ask them for more specific metrics in which the timetable so that we can measure how they're doing, which I thought was interesting. And then, after several years, if they haven't lived up to their promises, should we have any authority relative to that?
But we should call it that.
Yeah, so anyway, there was an interesting conversation about this.
Okay, so we'll figure it out, but not before we adjourn. So thanks everyone. I'm gonna stand in adjournment.